Well, good morning, everybody. My name is Jens Chapman, and welcome to the STED Talk edition from October 2nd, 2024. STED, as you always hopefully know, and our followers around the world will remember, stands for Spine Technology Education, and the D is for discourse, discussion, but in this case specifically discovery. And it's a great honor to have Dr. Matthew Kaeberlein here, a PhD. And I'm going to introduce him in greater detail later, but he's one of the leading experts on anti-aging sciences. And so it's great to have him here. He's obviously not a spine surgeon, and we will start with some spine cases, but these will be modified to kind of reflect our aging thoughts. So it's a real cool honor to have him here. Just in general, we survived the vice presidential debates last night in reasonably good shape, I think. And for those of us who celebrate the new year, happy and safe new year to you and your loved ones. And may the new year bring blessings and good fortunes to all of us. So on the specific scale, we'll have a couple of cases to show. Is Dr. Kaeberlein live?
Yes.
Good morning, Dr. Kaeberlein. Can I just hear a sound effect from you?
Good morning.
Well, it's really cool to have you, and we obviously know one another from our past UW background. I'm going to give you a more general or a far more specific introduction later. But again, we owe a lot to you for having put Seattle and the University of Washington and our scientific community in the greater Puget Sound area on the world's map with anti-aging sciences, and you're one of the leaders of that. And we really, really appreciate you taking the time to speak to us and our global audience today. Just very briefly, Dr. Kaeberlein is the chief executive of OptiSpan, and he's an active, ongoing affiliate professor at the University of Washington. And he has launched a couple of very groundbreaking projects in terms of longevity enhancements. So in this capacity, we in Spine are particularly keen on hearing and interacting with your research insights because it's a really big deal. Just a quick disclosure, I personally think that the spine should be recognized as an organ system, both in its musculoskeletal and its neurologic capacities. And aging clearly reflects in itself between genetics, trauma, and nutrition. That includes malnutrition, nicotine, et cetera. And these are topics that we'll confront you with, Dr. Kaeberlein, if we will. We realize you're not a spine surgeon, so we'll have a little spine surgery discussion on the side. But the aging or ill health reflects itself particularly in the spinal column. And one food for thought as we'll go into the first case is that two of our cell systems in our body that can't replicate themselves, meaning can't clone themselves, are particularly manifest in the spine. That's cartilage cells and, of course, neuronal cells. Most other cell systems can replicate themselves, but these two systems, chondrocytes and neural element tissues, can't really clone themselves, thus repair themselves, and that's a significant limitation. So, talking about the manifestations of this, we have Dr. Mark Kramer batting leadoff for us today, and he has a case that we are confronted with on an almost, certainly on a weekly basis. What'd you say? Dr. Mark Kramer, take the microphone, please.
Excellent. Good morning, everybody. So, first case, slides are up here. It's actually it's a very common problem we see in our aging population. In this case, it's approximately mid-80s gentleman who had a fall from standing. It was reported as a mechanical fall, and this initially he was initially placed in a rigid cervical collar. You can see on the across the sagittal CT, there's a type 2 odontoid fracture. He initially presented with neck pain and some balance issues. He does have a plethora of past medical history, including coronary artery disease, hypertension, hypothyroidism, et cetera, including, importantly, myasthenia gravis with some ocular manifestations. And he was on some chronic steroids for that. In terms of his initial physical exam, you can see he's 5'7", approximately 70 kilograms. He was full strength in the arms and legs. He was quite brisk in his reflexes, both uppers and lowers, and he also had a positive Hoffman sign bilaterally. Sensation was intact. So here's the initial CT, and I'll scroll through this briefly. You can see again, there's a type 2 odontoid fracture. not horribly displaced. If you roll through the facets on either side, there is some arthropathy as well, noted more so on this side over here. The coronal view again shows very minimally displaced type 2 odontoid fracture.
So, Dr. Kaeberlein, I know you're not a spine surgeon. We so appreciate you being here. As I said, this is something we see a lot of. So if you can go back to just the health history of that intro slide, and I forgot to mention Dr. Mark Kramer is a neurosurgical colleague from the University of Wisconsin, and we're proud to have him here. We see these stories all the time now. People in their 80s and 90s who come with multiple medical problems who fall and break their spinal column. Other bones also, but particularly the spine. Some statistics claim that I think ground level falls have become the second leading cause of unexpected deaths in North America. So here's my question to you, Dr. Kaeberlein. This is the key question of the whole morning for me. As leading edge scientists like you find new ways for us to get older, how can we kind of make sure that the other organ systems keep up with us? We have a lot of treatments, as you can see in this, for hypertension, hypothyroidism, prostate hypertrophy, myasthenia gravis, even a complex neural disease. But how can we keep the other organ systems in place? Or are we gonna, if you're successful, are we gonna create centenarians who are basically just decrepitly laying in wheelchairs? With this, I'll wait for your answer.
Yeah, thanks for that question. And I would suggest actually by targeting the biology of aging, we are much more likely to maintain health and function across many, hopefully all organ systems, as opposed to just keeping people alive longer. In fact, this is sort of my introduction. I think what we have done over the last 50 years is keep people alive longer, sick, because we haven't really modified the biology of aging. We have, reduced mortality in a variety of ways, but people are still aging biologically at the same rate, which is why we're starting to uncover the functional declines and the diseases of old age becoming much and much more prevalent. And among the functional declines, I think, are declines obviously in spine function, increased risk of fractures in other parts of the body that become much more prevalent because we haven't modified the biology of aging in a positive way, yet people are living longer. So the loss of function in those tissues and organs becomes much more problematic. So I would actually turn it around and suggest that by modifying aging biology, and I think this is what we see in laboratory animals, we do in fact preserve function, broadly speaking, at least across most organs and tissues. There hasn't, I would say the spine has been understudied in the field, but the little bit of work that's been done there, I think, is consistent with the idea that spine integrity and function, to the extent that you can study that in a laboratory mouse, is maintained better when we intervene in the biology of aging.
That's awesome. In terms of looking at your aging rats and canines, can you study them for adjuvant diseases? Is there any model for the civilization diseases like hypertension and other classic organ system problems, atherosclerosis? Are these things that are somewhat modifiable with anti-aging means, or is this just a sign of our genetics or bad environmental input?
Yeah, so the way I think about it is we absolutely see those age-related diseases in model organisms, particularly the more complicated model organisms like dogs that are especially living in the human environment. We see the diseases of aging, and they are age-associated in those animals in the sense that they go up exponentially with age. But every animal has a slightly different spectrum of age-related diseases in terms of prevalence. So you mentioned specifically vascular disease as an example. That is not a primary cause of death in either laboratory rodents or in dogs. Dogs in particular get a lot of cancers, a lot of arthritis, hip dysplasia in larger dogs, a lot of structural defects in the heart. We just don't see the vascular component. So I think the spectrum and prevalence of different age-related diseases differs a bit based on the animal that we're talking about. But as far as I know, all of the age-related diseases that people get do occur in these animals, just at lower frequencies for some of them, higher frequencies for others, and they are age associated. And indeed, when we intervene to modulate the biology of aging, we believe it does seem to protect against all of the age-related functional declines and diseases that people have studied.
Very cool to hear and very insightful also, and I appreciate your honesty about how some things are modifiable and others are not, and how some things can translate into the animal realm and others, again, are limited. Now to the key question. So when we encounter a patient, especially in the 80s, but pretty much anybody in their later years, one of the first things is neurocognition. So I'm going to ask Mark here. You're a neurosurgeon from one of the premier institutions in the US. How do you assess the neural capacities of a patient in terms of what their status is? You have an acutely fallen patient, 85, 86. How can you be sure, or how can you quickly, as a clinician, gather a meaningful appraisal of their neurocognitive capacities?
Good question. Of course, there are many tools out there. There's a variety of scales that people use. I personally never use those. You get your first impression of kind of how the patient's doing cognitively just by having conversation with them, if that's possible. The second part of it is really talking to the family, because they have a lot more insight into kind of how the patient's functioning on a daily basis. Obviously, in this case, the patient had an injury. You can talk with the patient's spouse or other people that live with the patient, get a sense for how they're doing, how much help they need for paying the bills, how much assistance they need for just taking care of themselves on a daily basis. I think all those things are important.
So this is a cardinal thing. Dr. Kaeberlein, back to you again. So I have in my limited lifespan as a practicing surgeon, so 1990 to now, been amazed at the rapid evolution of patients' age and activity expectations. I trained at the University of Munich in the 80s, early 80s, and there was an attending who wanted to do, all cases were reviewed by a large assembly of surgeons. And there was a surgeon who wanted to operate on a patient of 68 and do a total hip replacement. And the chair loudly, roundly poo-pooed that surgeon. I mean, just devastated him in front of the entire group. It resonates with me to the present date. How reckless and ruthless this was to waste monies on a 68-year-old who lived maybe to 72. Nowadays, 68, we shrug our shoulders. It's just a non-factor even. And we have patients in their 80s and early 90s who function dramatically. How much does the neuronal integrity reflect an aging, and how can we reverse neuronal aging? It's something that obviously has received a lot more attention as dementia and Alzheimer's have reached the mass media attention. So talk to us, if you will, about neuronal health and neuronal aging.
Sure. So first comment I would make, though, which I think your observation is spot on, although really only tells part of the story. I think you're right. We see a subset of people that are functioning at a much higher level, much longer, 70s, 80s. We also see a large majority of people who are getting sick much earlier. So there's this disparity in terms of health span that I think is really important to recognize. And there's a bunch of factors. We won't go into all of the factors that contribute to that, but it's certainly not the case that the majority of people are functioning better into old age. It actually appears, at least from a population level in the United States, to be a relatively small fraction. I know that wasn't your question, but I think it's important to recognize that. In terms of neuronal function in particular, again, my sort of overarching perspective here is to always try to move away from siloing certain diseases or certain tissues and organs and focus much more on what are the fundamental processes of biological aging that are by and large, not completely, by and large shared across tissues and organs. Certainly in certain cell types, you do see an increased relevance for some of the hallmarks of aging, such as mitochondrial dysfunction may be more prevalent in neuronal subtypes, or inflammation than in other cell types. But by and large, I think of the hallmarks of aging and the biology of aging as something that we are pretty confident we can target directly through both genetic and environmental mechanisms. So either lifestyle factors or pharmacology. And so I personally don't tend to think so much about how do we target cognitive function or neuromuscular function or cancer, right? I try to think of how do we target aging because it's going to impact all of those things. Having said that, I think, again, the simple answer is the best way to preserve neurological function and probably function, broadly speaking, across the entire body are the lifestyle factors that we know have a pretty profound impact on the biology of aging, right? So healthy diet, regular exercise, sleep quality, I think, is emerging as a place that has been understudied in this area, but is super important. Those are the factors that we know work, the levers that we know work, and then I think we can start to get more granular, look at kind of first generation, what I would call geroscience interventions that target the biology of aging. And the place where I really have over the last several years become much more focused are on the inflammatory processes that seem to be particularly overrepresented in aging, right? So anti-inflammatory is this catch-all term. Not every anti-inflammatory is going to have positive benefits on a variety of age-related diseases or the biology of aging. But and this is where I get outside my depth real quick because I'm not an immunologist, but there seem to be certain types of inflammatory processes or immune dysfunction that go along with the aging process, and interventions that somewhat specifically target those. Those could be clearing senescent cells, things like rapamycin, seem to be quite effective at, again, knocking down that age-related inflammatory response, boosting function across many different tissues and organs. And I think in terms of neuronal function, it's become pretty clear that these runaway inflammatory processes with age are a driving factor to a lot of the dysfunction that we see.
So one thing that I found fascinating as I looked at some of those blue zone studies is the phenomenon of socialization, or in reverse, isolation of aging populations. And those who have a rich social environment seem to age far better and have far more functionality and far less neural decline than those who are isolated. Again, we don't know whether one is the manifestation of the other or in reverse. So isolation is maybe an expression of a beginning dementia or neural decline. But are there any animal models that show that there's a decline of neuronal function in terms of isolation versus group activities?
Yeah, so that's a great point. And I kind of said the three of the four pillars that we think about a lot, which is nutrition, exercise, sleep. Connect is the other one, and that encapsulates that sort of relationship, social relationships, and social isolation is the flip side of that. You're absolutely right. That's really important. That's the one I would say we have the least understanding of the biological mechanisms so far. In terms of your question about animal models, so certainly environmental enrichment has been shown to have an impact on cognitive function and other age-related functional parameters in laboratory animals. I don't know how much has been done on the social aspect of environmental enrichment, but if you isolate individual animals versus put them in social groups. I mean, one of the things that's challenging is the way that sort of our animal use regulations have evolved. We typically actually house rodents in the laboratory in an environment that is not optimal for them in terms of their social environment. So the way that we're starting the experiment in some ways from a social perspective is a deficit compared to probably where those animals would be optimized. And so that creates a situation where you really have to wonder about experiments done starting from that baseline and then further isolating what that means. So I don't know the complete answer to your question, but I worry a little bit about the way that we are required to house animals in the lab, and is that artifactually impacting the way we can actually study this very important question?
Appreciate the honesty of this. Mark, can you go forward? So Dr. Abdul Jabbar is my partner, and he is at the Swedish Issaquah Hospital right now as he's going to do his OR today. Amir, this is an elderly patient. This is an everyday thing. You're on call right now. This could have happened last night, and it's not even a big ado anymore. How do you approach a octa or nonagenarian with a type 2 odontoid fracture with a number of medical comorbidities in terms of the decision of palliative care versus surgery?
Hey there, good morning. Can you hear me okay?
Yes.
Yeah, I think obviously these are very common fractures, with all these medical comorbidities. Obviously, this is kind of early in the timeline when before I had met the patient. But I think that one, some of these will heal. I think it's very low likelihood to actually heal. There are a large percentage that have a kind of stable non-union that's pain-free, and I think that that's probably the best outcome you could ask for if you're going to treat this patient non-surgically. And then patients that are in quite a bit of pain and limited, 3 months in a collar, ending up with a non-union is not a great kind of treatment course for many people. It's very limiting. And I think a C1-2 fusion in a very active patient is very reasonable and has a very high likelihood of success.
All right, so take us forward. Would you operate on this patient? It seems to be pretty with it, right? Amir, would you have operated on?
Yeah. I mean, again, this is earlier on. I haven't met this patient personally, but yeah. I mean, in an active patient that is very limited by their pain, I think it would be reasonable, even at his age.
And Mark, your patient, back to you again. Madison,
good.
Wisconsin. The patient responds favorably, lives in family, has social connections. We've stated the biologic burden. What would you have done?
And this is ultimately what happened to this patient. This patient was treated conservatively in a collar for 3 months. I think that's probably not an unreasonable first course of action, and kind of prove that the patient can't heal on their own. There's many things, I think, in this particular patient that would make that challenging, obviously the steroid use. Yeah, I think we probably would have placed this patient in a collar and let them fail before we offered a fusion.
All right, take us forward. Let's flash forward in time.
So again, to summarize, fall from standing, type 2 odontoid fracture, multiple comorbidities, hyperreflexic, interestingly. So in terms of the workup, the MRI was done just to make sure there wasn't anything else going on in the cervical spine. This is the upright x-rays and the collar that was initially trialed. And then this is going on at the 3-month mark. Unfortunately, there's this interval imaging here. You can see the CT on the left shows that there's obviously no healing across this fracture. And then on the flexion extension x-rays there, you can see a fair amount of translation, almost 6 millimeters. So at this point, a fusion was offered. The construct that was chosen at that time, again by no one presently here, was a wiring construct with a structural allograft posteriorly. And it sounds like this operation was uncomplicated from what I read. Unfortunately, now the patient did well for the last 5 years. And it was actually quite functional, living at home with his spouse, able to ambulate the last few years, has been using a cane and a walker, but now comes back in with about a month of very progressive, severe decline in both hand function and leg function. Again, he's still living at home, but his spouse is having increasing difficulties taking care of him. He's now well into his 90s. His exam is shown here. He's now got diffuse brisk reflexes in the upper limbs, not so much in the lower limbs. And he's got weakness now, both of the right and left arm, in addition to the legs. So an MRI was initially done, and just through the hardware there, it's very difficult to tell what's going on, so we actually ended up getting a CT. So this is the CT that is done. And you can see that there's essentially still no healing across that odontoid fracture, but we're seeing kind of the development of some callus, pannus, kind of posteriorly there. And if we look closely, there actually may be some failure of some of the hardware posteriorly. So question is, what do we do now?
Amir, so before I go to Dr. Kaeberlein, technically speaking, one question by the Mark, was this autographed or was this allograft?
Good question, I don't know.
Was the patient immobilized with a halo afterwards or a rigid neck collar?
Rigid neck collar.
Yeah. So Amir, thoughts of operating or not? 90s?
I mean, Are we talking now or are we talking initially? Because now, this patient is pretty acutely myelopathic. And just one comment, I think when you're looking at that, as opposed to that being pannus, I think that's actually the C2, the odontoid tip that's now moved backward that we're seeing that's now impinging on the cord. So this is a much more challenging surgery. Obviously try to avoid going to the occiput in this patient. But the anatomy is now much more challenging to do. Just to C1-2 fusion, it may be necessary. So this is a much more challenging surgery. I think if you do nothing, he's pretty much guaranteed to keep declining neurologically. And so this is a challenging discussion to have with the patient. So I think it's hard not to offer a patient who's very functional a surgery, but in a 92-year-old, this is very high risk, and it will be a challenging surgery.
So for Dr. Kaeberlein, what I have seen is that patients outlive our treatment expectations. Assume, I'm not a spine surgeon, that this treatment offered was a old school kind of an inexpensive treatment. It makes everybody feel better. The real treatment for this, as I inferred, would have been to take bone from the pelvis. That was obviously not done. It's an additional morbidity. The patient ideally would have been in a halo, so a big ring with a vest, which is very disabling, especially for older patients, and has a high risk of pulmonary problems. So this is a classic example. This is why I thought this is such a fascinating case of a compromised care that was done. Because the surgeon, and I don't know who it was, I don't know anything about this case, anticipated that this patient in the mid-80s would be gone in a couple of years. The treatment would outlive the patient, so to say. And they don't do us this favor with excellent medical care and keeping all those adjuvant comorbidities in check. The patients outlive this, and now we have a real so we have a very, very challenging situation surgically and age-wise. So this patient in their 90s now did not get healthier along the way. And now we have an incomplete spinal cord injury with a significant disability from cord pathology that may not be and is not going to be fully reversible. So your thoughts on how we as clinicians can kind of estimate length of life expectations? Should we give them the optimal surgical care? How does kind of a compromised care, I'll call it an NHS care, a British version of just kind of doing the absolute minimum necessary, kind of hoping that the patients will not make it past our treatment? How do we apply clinically?
Wow. Well, first of all, that's way outside my my area of expertise. So I can give you sort of my thoughts, but I would not suggest that I have any insights that you don't already have. I mean, I think it's clearly a challenge, the fact that people are living longer, but again, I sort of alluded to this earlier, aren't necessarily living healthier. So where do you draw the line? Yes, obviously, if money was no object, we should give everybody the best possible care that we possibly can that's going to give them the longest horizon on whatever it is we're trying to fix. The other optimal would be to be more proactive and keep people from developing these functional declines and diseases of aging in the first place, right? Neither of those are realistic given where we're at now. So obviously you land somewhere pragmatic. I think the question maybe that you're asking or partly asking is, what does the future look like? If I was to project out 10 years, 15 years, do we anticipate that people will continue to live longer and longer and longer so that maybe the pragmatic sort of decision point shifts more towards the more intense, more expensive procedures that will maintain function longer? And the honest answer is, I don't know. I mean, if you look at life expectancy today, it's plateauing at the national level, at the population level in the United States. But I think we have this huge disparity that I alluded to before, where the people who can afford the best care are continuing to live longer. And I think we probably will see that going into the future. I think it will be the case that we will continue to have those who can get access to the best care maintaining function maybe another decade. And that's without any additional technology or science advances in the biology of aging, in geroscience. Depending on what happens there, especially with the new AI tools that are coming online, we could see significant increases in life expectancy for those who can get access to those technologies. Now, by significant, again, you'll get answers all over the board as to what that means. I think it's conservative, given the field that I operate in, is like maybe 20 years is what we're talking about. But that's a pretty big deal, right? If we had a technology that could increase life expectancy by 20 years in the next 5 years for those who can get access to it, that's a pretty big change. And I don't think that's outside the realm of possibility. So yeah, I think you should anticipate that your clients who can afford the best care will likely continue to see gains in life expectancy going forward.
Fantastic. So we've kept you standing up here, and we have two other fellows to present some cases. Mark, how was this resolved?
Not resolved yet, actually. This is
So what's going on?
So we are in the process of getting a myelogram, so we can get a better sense for what the canal looks like up at that C12 area.
So I think that's very reasonable. So for me, the recommendation there would be actually, and Matt, this is something we're doing, Dr. Kaeberlein, something we're doing more and more often. We involve palliative care. Just like gerosciences is a new word for me today, palliative care has popped up out of the last 15 years medical realm dramatically. And we very frequently find us in these boundary situations where ethics and medical feasibility collide. And we try to coalesce them somehow with the help of palliative care to ask questions of quality of life, end-of-life visions, and risk-taking endeavors within patients and their families. It's a difficult thing, but again, add palliative care to gerosciences. Amir, what would you do? Would you offer surgery to the patient?
So yeah, this patient just came in last night. We're still in the process of making that decision. The one other thing that I thought of was, possibly CT angiogram. I don't know if you can see it on those images, but there is kind of an aberrant vertebral artery anomaly, just to make this an even more kind of complex case technically. But yeah, that's something that I was thinking about. And again, we would have to have that discussion with the family, make sure that all on board really understand what the risks are, and we'll definitely, if the patient understands and wants to move forward, I don't think surgery is out of the question.
No, I would, by the way, go to the occiput. And we too think alike, try to save the cranioscervical junction, but I would go to the occiput in this age group and go down to the subaxial spine like C5, C6, into that stable ankylosed zone. And I would involve personally palliative care. I find it, in all of our fascination with biology, I find the ethics and social discussions, Dr. Kaeberlein, so important. And I really appreciate our colleagues who have these very difficult discussions. I think they should be separate from us as surgeons. So thank you for this discussion, Dr. Kramer. And we have Dr. Minisali, who came to us from Rothman Health East Coast. He's a diehard Phillies fan. And he loves his Eagles, and it's great to have you here too. And he has a different slant. He has two cases, and we'll have to kind of do those within 10 minutes or so, Nick.
Yes, sir.
And they have a different slant now on this very profound ethics discussion that we just had.
Yes, thank you so much. So this case is a lower 80s-year-old male with low back pain, severe left lower extremity and buttock radiculopathy, no prior spine surgeries. Fairly healthy individual, given, again, his age, some BPH, mild controlled hypertension, and glaucoma, utilizing medication for that as well. Socially, non-smoker, no alcohol use, lives at home with his wife, very active, often takes prolonged hiking trips. Very recently did 30 miles on one trip. On exam, some mild symmetric low extremity weakness, no pathologic reflexes, pretty decent range of motion except for forward flexion. As far as imaging, we have AP and lateral flex X-rays demonstrating this stable high-grade 1 L5S1 isthmic spondylolisthesis with foraminal stenosis greater on the left than right, as well as some mild retrolisthesis of L4 on 5, all in the setting of dish from about L3 to higher. Our MRI demonstrated moderate and severe foraminal stenosis at left greater than right, L4-5 and L5-S1 respectively.
And good. So Dr. Kaeberlein, as non-spine surgeon, this is something we're confronted with all the time now. This is a man in his 80s. He is not quite 85 yet. I'll just go there. We don't want to offer too many specifiers, but extremely active, completely with it. Bright eyes, highly engaged. And this is, assume in our world, common. And frankly, in a 60, 70-year-old patient, we'd expect these degenerative changes. He has, by the way, inflammation. We can see it in the lumbar spine. We call that DISH, D-I-S-H. These kind of candle wax overgrowths in multiple segments of the spine. The spine wants to self-fuse. So a manifestation of an intrinsic, deep-rooted inflammatory process. He has a very common condition at the bottom, which will not paralyze him. The spine has slipped out of place. We call it a grade 1 to 2 isthmic spondylolisthesis, and he has stenosis at the next higher level. But again, he will not become paralyzed. It's an irritant. And how do we as a society function with this? You mentioned something before about for those who can afford it or gain access to care, a very hot topic. So here's an 80-year-old plus patient who is highly active, highly engaged, intact family, comes with 4 or 5 very actively participatory family members, and he wants to walk, move. Do we as a society tell somebody like that, no, because you're too old, or how do we handle that?
Yeah, I mean, I guess my perspective is that, and I think you and your colleagues kind of do this anyway, but I think we need to shift towards thinking about, rather than what somebody's chronological age is, what is their biological age? And that's challenging, and I'm going to talk about this a little bit, like how do we even define biological age? But function is part of it, right? And I think you've just said it. There are plenty of people out there who are chronologically 80 plus years old, but are functioning at the level that if you looked at the population, might be the function of a 63-year-old, right? And so I think as we're making decisions about what type of care is appropriate, I personally think it's a mistake to use chronological age as a determining factor. And again, I know you already do this, but I think it would be great if we could start to move towards some consensus definitions for what do we mean by biological age, and how can we use that as maybe a more appropriate metric for determining what the right care is for each individual patient.
Because if I may extrapolate on that, my own uncle in England, mid-80s guy, super fit, became progressively disabled from stenosis. And again, in the standard NHS system, they just told him, you're in your 80s, go get a pint of beer, use a cane, go to the next pub. I kid you not. And it's only due to personal connections in Cambridge, a neurosurgeon there overrode the GP and did surgery on him, and it was nearly curative. So it's something where in that other society, they have no problem there telling their practitioners, no, you're in your 70s, in fact, and you're too old for the surgery. We're going to shut you off. So certain healthcare systems with a large single-payer monopoly actually do that already. They just shut down, for instance, spine care, and spine problems can be very disabling. So tell us what we did here, Nick.
Yes, so this case is resolved. We performed a decompressive L4 to S1 intradiscal osteotomy with deformity reduction, posterior instrumentation from L3 to pelvis using local bone graft as well as allograft. And of note, this patient did very well after surgery and was discharged to home on post-op day 3, which is, I would say, faster than the average patient. And then in comparison, we actually have an interesting case, much more brief here, but basically late 60s-year-old male, similar symptoms, prohibitive worsening back pain, leg pain, inability to walk, or progressive inability to walk, still able to ambulate, but also non-smoker, no alcohol, lives at home with his wife, active, golfs several times a week. Overall, slightly higher BMI, but again, a healthy patient, much about 15 years younger, who underwent a very similar surgery. So you can see our pre-op films and our post-op films. This was 3 levels of, we did L2 to 5 intradiscal osteotomies as well as fusion, and this patient really had no complications, but remained in the hospital up to 2 weeks, and it actually was discharged to an acute rehab care facility. And again, comparing the 2 cases, similar overall and very different kind of ambulatory status afterwards and things like that, and really no complications from a medical standpoint. So we thought it would be interesting to kind of discuss this, given their differences.
So Dr. Kaeberlein, beyond the spine surgical thing, assume that we have, through technology, companies, better tech, better technique, way better ways to, quote, fix or treat spine problems. And the spine, again, being a manifestation of an organ system that fails as it reflects our aging process. This patient had, in his 60s, a wide laminectomy done by a colleague who felt that this patient was older, although the patient is mentally very active, works for a living, entrepreneurial, and a golfer, did a inexpensive, anachronistic, almost wide decompression surgery to alleviate neurologic symptoms. And the patient kind of doggedly trucked on, could have been a Brit in that way, just trucked on, kept going, and then was very disabled, and we had to do a very complex revision decompression. Arguably, had this patient had a fusion surgery in the beginning, a more expensive complex surgery, this would have not happened. And he struggled far more because of his prolonged period of disability than our 80-year-old who had a invasive procedure right away but just bounced back. So the point is, predictive analytics, I know you're a basic scientist of the first order, but where are we with predictive analytics? Are you able to kind of have, on a molecular basis, any predictive capabilities like telomeres, et cetera, something mutation-wise that tells us where patients or organisms are in their senescence cycle?
Yeah, great question. So this is an area where the science has advanced quite rapidly over the last 10 or 15 years, this sort of proliferation of what people now call biological aging clocks. And I really don't like that phrase, but what that really means is people have developed different molecular markers that can assess biological age as defined by future mortality risk or future disease risk using different types of molecular information. So epigenetics is the one that is most common. And these epigenetic age clocks have actually gotten to the point where we have the sort of first generation of organ and tissue clocks that may be able, from a single, for example, blood test, to predict organ epigenetic age in the same individual, right? And so the idea would be you could, if this technology actually pans out, give a patient a blood test and identify, is it their heart, their brain, their kidney, maybe their spine. I haven't seen anybody look at the spine using these tools, but in theory, it should be possible. Where is it that we're starting to see the pathology that is a result of the biological aging process manifest itself? And then we can see it as epigenetic changes, which are probably reflecting underlying dysregulation of gene expression. So epigenetics is the farthest along, but there are probably 8 or 10 other molecular types of information that can be queried in the same way. Essentially, if you have a large enough dimensionality of data, you can identify these predictive signatures. The, I think, bigger question from my perspective is, can we get to mechanisms? So it's great to have a predictive signature, a biomarker, but can we get to biomarkers that are actually tied to the mechanisms of biological aging or the mechanisms of disease pathology? So I think it's still pretty early, but I'm really optimistic that these tools will get to the point where they're actually, I mean, they're already starting to be applied clinically. And unfortunately, in my view, they're being more broadly applied direct to consumer, which I think is not a great look. But I think they will get to the point where they're actually quite clinically useful in the next 5 to 10 years for sure.
Are people like yourself, who are obviously really insightful in terms of biology of aging, asked by larger emerging bodies of predictive analytics and again, health sciences applications for aging patients, are they invited to participate in these kind of decision-making bodies that predict future healthcare needs and the ethics of applications therefore?
Yeah, From my experience, there is not that extensive sort of dialogue yet. Hopefully, we'll get there. I think the field of what I'm going to call geroscience, which is biological aging, the science of aging biology, is still relatively young enough that it has not permeated at that level of the mainstream conversation. That's changing, definitely changing rapidly in the last 5 years as more and more interest, as the science has matured, more and more interest is accruing. But as far as I know, those conversations are not happening at any sort of real scale yet. They need to.
Yeah, sorry, because this would be a big deal for me. What I'm worried about, and these two cases illustrate that for me, is that a predictive analytics tool, let's say ChatGPT for healthcare, by medical administrators or health plan to say, we will do these less expensive surgeries. They'll use qualities or something, a metric to predict quality of life years on a numeric fiscal basis, and then apply a clearly subpar surgery like what was applied in this patient, which then when it fails, because yet again, the patient outlives the surgery, requires a far more complex and far more expensive, also rehabilitation-wise, lengthy recovery. So that's my, if I may be frank, biggest worry, that somebody will apply some algorithm in some AI sphere, a co-pilot, a medical co-pilot of sorts, a DAX, to tell us what to do. And so I would appreciate all those entities who make those decisions, including basic scientists like yourself who have a uniquely in-depth perspective. We'll go for one more pair of cases. Thank you, Dr. Minisali, that was very good. And we have Dr. Cameron Hogshead from Dallas, Texas, diehard Cowboys fan, similar to Dr. Minisali, week to week in his football fortunes. Glad to have him here. Talk about two cases, and we'll be finishing exactly at 7:30 to take on and be treated to Dr. Kaeberlein's lecture.
Yes, we both share in our woes of being Cowboys and Eagles fans collectively. It's a 78-year-old male with recurrent right lower extremity pain and weakness and numbness. So he's had significant walking difficulties. That's a sagittal of his most recent MRI. Leg greater than back pain, and also reports right ankle is starting to drop and knee buckling. He had these symptoms evolving prior and had a previous surgery for this in 2014 and had a lumbar 4-5 right laminotomy microdiscectomy, which gave him relatively good relief and some recovery of his strength, but residual deficits were still noted when he presented back recently. He's got a past medical history of hypertension, hyperlipidemia, previous transischemic stroke, obstructive sleep apnea. His relevant social history denies all tobacco, chronic alcohol, or illicit drug use. Looking at his score, you can see his exam there and the foot drop as well as the decreased strength in that L4, L5 distribution. He does have some dermatomal hyperesthesias as well, unable to toe or heel walk, no bowel or bladder symptoms. And then upon kind of looking at his labs, you can see he does have a very low albumin, 3.0 in 2019. And then in recently, looks like it's dropped in between then. And in between those years, he did have some hospitalization for COVID and was ill between that time. These are x-rays of AP lateral lumbar films demonstrating pretty severe disc height loss at L4, L5, and 5-1 there with significant spondylosis present. This is an MRI scan here, and you can see demonstrating that 4-5 disc desiccation and collapse, and then reherniation of the level above causing foraminal as well as some central canal stenosis, likely contributing to his symptoms. And so this was kind of a case looking at reherniations of discs and disc health in general and related to the setting of however we would define malnutrition or malnourishment. That's kind of always a point of contest and usually kind of described as clinical findings in addition to labs such as albumin and transthyretin, which in his case, his albumin was representatively fairly low. 2.2. And whether
And
this
why
is,
was he so, sorry to interrupt you, why was he so malnourished? Do we know that?
not sure, he's
No kidney disease?
no
liver
kidney disease, no liver disease.
No absorptive disorders?
No absorptive disorders. The only thing I could find is he did have multiple bouts of COVID and hospitalizations between the year.
So Dr. Kaeberlein, I'm showing you, or we want to show you this case because as spine surgeons, we feel, I think collectively, that the spine, for instance, represented in x-rays or MRIs specifically, shows a very unique, and that's a beautiful slide, and I'll have you comment on that in a second, Cam. It shows a unique report card of a patient's wellness in terms of integrated genetic, nutritional, and trauma factors. So do you want to just verbalize that slide quickly?
Sure, yeah. So he underwent revision surgery with good relief of his symptoms, and there's always the question of, how am I going to prevent this disc from reherniating again? How are we going to prevent this problem from happening again? And you can see from that kind of flow chart there, that there is multiple players in terms of, and this has been a highly researched topic of disc reherniation and disc health, and multiple players in terms of your metabolic health, your circulation health, nutritional health, represented by particular labs like albumin, your transthyretin, your total lymphocyte count, ESR, micronutrients, vitamin B, all those things. And they found that basically, if you are at a higher risk of smoking, diabetes, malnutrition, being a male in general for whatever reason, grade of disc degeneration, annual defect, and then they also looked at kind of the effects of sarcopenia around the spine and the health and core strength and fitness of the individual. And Gatellia grade of the paraspinals has led higher grade, which relates to higher fatty atrophy of the muscle, leads to a higher risk of having a disc herniation and disc herniation in itself.
I thought this is a great, did you make that left graph?
This is from that
This is from the
paper right
article.
there.
Yeah, because it's a beautiful thing, and thanks for doing that. So the discs are a unique bioreactor with hypoxic cellular environments. Those chondrocytes live in a hypoxic environment, merely sustained by diffusion through the vertebral bodies, which in turn gather their bloodstream, their blood flow through the aorta, and it's a amazing circumstance, anoxic and actually acidic. So I'm not aware of another cell type that has to have this narrow zone of comfort, and thus it's very easily affected by things. So protein health, DNA expression in the disc is manifest there. Has anybody in your anti-aging efforts looked at discs and the spine as a representative of overall biologic health?
Yeah, so I don't have any direct experience. I've come across a couple of papers that have looked at disc aging and the effects of interventions on molecular features, gene expression features of disc aging. But to my knowledge, this is a really understudied area of aging biology, which unfortunately there are quite a few of those. I mean, I think for obvious reasons, the field has largely focused on the things that you can get NIH funding for, which is largely centered around the major diseases that are broadly funded by NIH. So I think this is an area where there's probably a lot of sort of foundational work that can and should and needs to be done, and I just don't think it's been studied at that depth.
Good. Now, for us, this is obviously something that's our world, but I always loved and feared the vulnerability and the unique adaptive survival characteristics of the human intervertebral disc, specifically as bipeds. So why don't you take us forward?
So this is another case somewhat related to matter. This is a 70-year-old male chronologically, probably physiologically, as we were discussing earlier, a lot later years. I presented with bilateral upper extremity and lower extremity weakness. Kind of an interesting story. He said that his legs gave out and he was down for 5 days in his hotel. He's been living out of a hotel for the last week now, and kind of when his time expired there that he paid for, people actually found him there down and brought him to the hospital afterwards. He said he didn't have enough strength to get up off the ground. He was a previous independent ambulator and now requires walker obvious assistance. No past surgical history. His past medical history, he's None reported, but he hasn't seen a doctor, does not coin one as going to a doctor regularly for visits. He has noted on his exam chronic venous stasis ulcers bilaterally. He did have a significant amount of pitting edema to the lower extremities as well, and also found on further investigation great toe cellulitis and ulcers. So already kind of some signs of a poor healer and high-risk patient, given kind of his compromised health circumstances. Social history was a tobacco user, also admits a previous methamphetamine use, and does have a chronic alcohol use as well. And then you can see his sagittal T2 of his MRI there with some myomalacia at 3-4 and some significant canal stenosis at 3 to 6. No bowel and bladder symptoms for him. He did have numbness in the hands and feet and a stocking glove distribution. This could be contributory from multiple things such as spine or possible chronic alcohol use and polyneuropathy. He did have loss of hand dexterity over the last year or two with obvious significant gait imbalance and instability as NEUROC 4 and severe MJOA 9 there. Looking at his labs, and expecting significant malnourishment, among others that we discussed. He did have some labs really reflective of chronic alcohol use and some malnourishment, but at folate, the level that was low, did have a bili elevated. His liver markers were elevated such to reflect chronic alcohol use as well as low platelets. Albumin was low, but not terribly low there. Looking at kind of the cirrhosis criteria, he was about a child, it's Pew A, which is the most mild form of that grade, but for predictive abdominal surgery, about a 10% mortality. And then the predictive model from that grading criteria gives him puts him at 15 to 20 years life expectancy.
So we need to kind of move.
Yeah, this is a CT scan here quickly, and we can just skip that and go to his MRI.
Severe cord compression, myelopathy, cord blanching, so very dysfunctional, difficult social circumstances. And if you don't mind going forward to the surgery, yeah.
And this is how he's treated with a ACDF levels 3 through 6 at those most compressed levels, and CT scan post-operatively.
So this is a really nice case juxtaposition. For me, if you go back to that MRI maybe, Dr. Kaeberlein, and this closing moment of the case presentations, for which I thank you in participating with us. How much do we know about alcohol, nicotine, vasoconstrictive drugs, and their impact on cell survival, cartilage survival, for instance? Is that something that's been studied selectively? How does this pre-age patients and affect the collagen ultrastructure?
Right. I mean, again, I think it's clear that alcohol abuse accelerates at least many aspects of biological aging. I think this question of, is there a moderate consumption of alcohol that's protective? That's a complicated, probably we don't have time to get into that, but overconsumption of alcohol clearly accelerates many aspects of biological aging. I guess the way I would also frame it is, and you sort of alluded to this earlier, these things are all tied together, right? So if you are not sleeping well, if you are metabolically perturbed, that is also going to negatively impact the biological aging process in multiple different tissues and organs. And so if you're abusing alcohol, you're not going to sleep as well. You have a higher likelihood of being metabolically perturbed. I think that there's many reasons why you can point to molecular explanations for the observation that that I would put alcohol under poor lifestyle habits accelerate biological aging.
Yeah, no, just mechanically speaking, patients who do these mind-altering drugs frequently pass out with their head tilted forwards and overload their discs. They're metabolically impaired already, nutritionally deprived, have bad calorie intake with alcohol as opposed to protein-rich, nutritionally well-balanced meals. So they fall asleep and they overload their discs, and bad things happen. Then with nicotine, you create a malperfusion of your vessels, the microvessels. Microvasculature is dramatically damaged to nicotine users and probably to some degree never repairs itself. So this is a really kind of a cataclysmic final product in which we then ended up doing surgery with titanium and organ donor bone grafts, hoping for a good healing. And of course, if this patient does not undergo a dramatic lifestyle change, other disc lobes will probably fail. What would you have done in Texas with this patient? Would you have operated, or would you have put him
Given
into
it-
rehab first?
Yeah, I think given his progressive neurologic decline, kind of his inability to get up and eat and use the bathroom and function to his weakness, we would have probably done the same, operated and then kind of get a good social support, social worker, case management, aggressive physical therapy, occupational therapy, give him the best chance of literally physically getting back up on his feet, moving again.
Great. Okay, thanks for the cases. Thank you to our 3 fellows for putting that together. Distinct honor and privilege for us indeed to have Professor Matt Kaeberlein here. Just for our audience, you can't see it, it's reflecting too much. This is a synopsis of a very rich academic life. Professor Kaeberlein is Chief Executive Officer at OptiSpan, which is a healthcare technology company that looks at innovative tools for 21st century medicine. And he's one of the leading investigators of aging and anti-aging. As these cases sought to illustrate, the spinal column is a primary target of aging in ways that a lot of people don't think about. They think about brain health and heart health, et cetera. But for us, the spine is a interactive organ system. In terms of past history, Dr. Kaeberlein is Professor of Oral Health Sciences at the University of Washington, co-founder of the Dog Aging Project. I had the great honor to meet him in my time at UW, and he was one of the big stars of the emerging UW protein scene and longevity scene. He has over 250 scientific papers. He's a fellow in multiple new arenas in medicine, the American Association of Advancement of Science, American Aging Association, and Gerontological Society of America, and has too many foundational interactions to list here. But he is the actual founder of the Healthy Aging and Longevity Research Institute and Biological Mechanisms training program at the University of Washington, has made a lasting impact there. And we're very blessed to have him here in our Seattle arena, and specifically engaged with SSF and his work. And I find it fascinating to learn from our molecular scientists, not just in terms of the underpinnings of our cellular systems, but also in the bigger picture of how we can apply that possibly in our field. I should also mention that Dr. Kaeberlein co-founded 2 companies, Aura Biomedical, for longevity drug enhancement, and then OptiSpan, a integrative healthcare technology corporation that I mentioned earlier. So really cool to have you here, Dr. Kaeberlein. Thanks for lasting through our spine cases. I hope this showed you that we're all kind of affected by what you're doing, and hope for some insights to help our patients. And really curious to hear your thoughts on anti-aging and where we are with our scientific insights.
Great. Thank you for that kind introduction. And I do have to say, I've been thinking more about the spine over the last couple of days. So I actually last week or 2 weeks ago had my first whole body MRI. And the only point of concern that came out was my spine. So I may send you some images and call on your expertise there for help. So what I thought I would do today is give sort of a start with a relatively high-level overview of some of the ways that my thinking around health have shifted as I've transitioned out of my primarily academic career into my new role at OptiSpan. And so it's going to be maybe a little bit provocative, we'll see, but the title Medicine 4.0, you might be wondering, what do I mean by that? And I'll get into that. And the role that I think longevity science can play in the hopefully next phase of healthcare, and how we get there. So what is Medicine 4.0? And this is really inspired by some conversations that I've had with Peter Attia, who's a friend of mine. Probably some of you are familiar with Peter's book and his podcast, which is pretty popular. I've been on the podcast a few times. Peter talks a lot about this transition from Medicine 2.0 to Medicine 3.0, going from, scientific medicine that is primarily focused on reaction and focusing on individual diseases in isolation to something that is more proactive, hopefully personalized. And I've been thinking a lot about that, and actually have decided that maybe we need to just skip over Medicine 3.0 and go right to Medicine 4.0. And I'll tell you why I think that. So just to introduce a few sort of very basic concepts here. We've already talked about chronological age. and everybody understands lifespan, the time from birth to death, easy to measure. Health span is, I think, conceptually also pretty easy to understand. We all sort of appreciate that health span is the high functioning period of life. But exactly what that means, I don't think we've settled on a consensus definition. In fact, I know we haven't. And one of the challenges is that health is not binary. You don't go from having 100% health one day to having 0% health the next day. So it's really hard to define, when does health span end? Because health isn't binary. And so at this point, one of the unfortunate aspects is we have a lot of people, especially in the scientific literature, defining health span and just making it up. And it's not that the made up definitions are unreasonable, it's just that they're all different. And that's a challenge when we're really trying to think about, what do we mean, whether or not something can increase or something decreases health span. So this is an area where I see there's a little bit of a need for more rigorous thought and a move to consensus. I also want to just explicitly talk about the two types of aging. And again, we've already touched on this. Chronological age, very easy, right? How old you are in units of time, the number of candles on a birthday cake. Biological age, again, a little bit harder to define quantitatively, but we all sort of get it conceptually, how old your cells and tissues are based on their physiological function. The couple of points I want to make is, again, it's correlated with, but not necessarily equal to health. And in particular, I think it's pretty easy to think about experiences where somebody can have a pretty dramatic decline in health that has not impacted their biological age. So again, in my field, I think this has been used a little sloppily in terms of suggesting that biological age is equivalent to health or health risks. And they're correlated, but not equal. And the other thing I want to mention is, just like with health span, there is not yet a consensus on how we measure biological age, but we all sort of get it. And I like the comparison of dogs to people, because everybody sort of understands that dogs age about 7 times faster than people do. 1 human year is about 7 dog years. All that means is dogs are aging biologically about 7 times faster than people are. They get all of the same age-related diseases that we do, and they're age-related in dogs. It just happens at an accelerated rate. One of the interesting things about dogs that those of you who have had dogs may appreciate is big dogs age faster than small dogs. So within species, there's this interesting body size effect as well that seems to modulate the rate of aging. And we know a fair amount about what is causing biological aging at the molecular level, or at least contributing. So I'm not going to take you through all of the hallmarks of aging. This is certainly not complete, but it's a pretty, I think, good representation of how we understand biological aging at the cellular, molecular, physiological level. And these are things like genome instability, telomeres, which came up, epigenetic changes, which came up. There are 12 of these things. We may have 15 in a few years, but I think they're a nice handle on what are the processes that are happening with biological aging and seem to drive many of the functional declines that go along with biological aging. And if you look in the middle of this wheel, you'll note that I've kind of put all of these arrows in there. That's just meant to represent that these hallmarks are interconnected. And I think what I have spent much of my career studying is the underlying network and the proteins and metabolites that act in that network that seem to modulate these connections between the hallmarks of aging. But that, again, I think we're still pretty early in our understanding of exactly how that network functions. So one thing I do want to suggest, though, is that you can use the hallmarks of aging to some extent to measure biological aging rate. And I alluded to these epigenetic aging clocks. So what we're really looking at in the case of these epigenetic aging clocks are methylation marks on DNA. And epigenetic changes is one of the hallmarks of aging. And you can identify specific locations of epigenetic changes that correlate with chronological age, and you can identify a different set of epigenetic changes that seem to correlate with mortality risk, disease risk, potentially representing some aspects of biological aging. One of the things that's really interesting is if you look across species, and I'm going to go back to this human to dog comparison, you can actually see, using the same epigenetic signature, the faster rate of aging epigenetically in dogs compared to humans. So this is work from Trey Eidecker and Elaine Ostrander several years ago now, 3 years ago, 4 years ago in Cell Systems, where they showed that using the same epigenetic signature, comparing dogs to humans, the human here, of course, is Tom Hanks, that dogs are aging about 7 to 10 times faster than people are, but it's nonlinear. And what I mean by that is early in life, dogs are aging maybe biologically 15 times faster, and then it kind of flattens out towards the later stages of life. And this matches up really, really well with these charts that you've probably all seen if you've taken your dog to the veterinarian, where they compare dog years to human years. That early in life, dogs are aging much more rapidly compared to humans than they are later in life. So I think the fact that we can recapitulate that using these epigenetic age markers tells us that indeed there is something fundamental here about the connection between the hallmarks of aging and the biological aging process that we see in these animals or across species. And I think, again, the real question is mechanistically, how are these things connected? Okay, so then the last definition I want to leave you with, and I've used this word a lot already, is geroscience. And all that really means is the biological mechanisms that are connecting biological aging with disease, functional decline, and disability. And this is at the molecular, organellar, cellular, tissue, organ, whole animal level. What are these mechanisms that cause biological aging to manifest itself as functional declines and diseases? And if you look at most of the major causes of death and disability in developed countries, they all have this relationship that they go up exponentially with age. So this is a semi-log plot. It is a logarithmic scale on the y-axis, again, just showing that all of these diseases increase essentially exponentially as we get older. And so that, I think, clearly suggests that there is a strong connection. And if we can understand that biology of aging, we can understand a lot and potentially have some impact on these diseases. And in fact, if you look at the top 10 leading causes of death in the United States, 9 of them have age as their greatest risk factor. The only one that doesn't is accidents, which also includes opioids. All of the other top 10 have age as their greatest risk factor. So clearly this is an important connection that we should be paying more attention to, I would argue. So how does this tie into my thoughts about, healthcare and the approach to medicine? So one of the things I don't think anybody can really argue with is that our entire healthcare enterprise, all the way from basic research through biomedical, drug discovery, pharmaceutical, drug development, clinical practice, is largely focused around disease. It's largely, not exclusively, but largely reactive. And we typically think about these diseases in isolation, right? And so you're a cancer doc or a dementia doc or an immunologist, right? But we don't really think a lot about what are the connections that tie all of these diseases together. And so we can ask the question, has that approach had an impact on health at the population level, or at least contributed? I certainly wouldn't want to suggest that everything about our population level health is because of the way that we have approached healthcare and some of the, I think, systemic challenges with healthcare that we see today. But if we look at the population level in the United States, it's pretty interesting. And I really hadn't appreciated this until I really took a deep dive into the numbers. So we can think about this different ways. If you think about survival at the population level, the median life expectancy in the United States today, depending on who you ask, is somewhere between 77 and 82 years. But at the population level, it shows these sort of Gompertz kinetics of survival. If we try to do the same thing for health, and this is challenging, so admittedly, I sort of made this up, but if we try to do this for health, we know that health does not track with survival, right? People lose health before they lose survival. And again, this is a population exercise. So as we sort of alluded to, there are subsets of the population that do better than the average population. This is looking at the average population. One way we can think about this is to look at life expectancy, which has plateaued, right? So we had a dramatic increase in life expectancy for the first half of the 20th century, probably mostly due to antibiotics, sanitation, improvements in child mortality. And then recently that's flattened out. And I don't know that I don't think we know what's going to happen going forward at the population level. Is it going to start going up again? Is it going to go down? Is it going to stay flat? One thing we do know, though, is that the number of people with chronic disease has increased dramatically. So the median age in the United States is about 38.8 years. 60% of people, according to the CDC, have at least one chronic disease. Everyone in this room can do the math and recognize that means that many people are living with at least one chronic disease for multiple decades. And so if we define sick span as the period of life with at least one chronic disease, I don't think there's any question that that's increased in the last 40, 50, 60 years. That also accounts for about 90% of healthcare expenditures. And that chronic disease rate and healthcare expenditure number, they're both going up. And I don't know how high they can get, but I'm pretty sure it can't get to 100, either one of them. So I think this is a challenge that we need to start facing, or there are going to be some really significant problems in the future of healthcare if we don't do something about these trends. So as I sort of alluded to, I think this is Peter Attia's book. He's certainly not the only one to be talking about proactive preventative healthcare, but I think he's laid this out in a way that can capture a larger audience, maybe can resonate more with a larger audience. But the idea is to keep medicine 2.0, we still need to treat sick people, but to focus more on proactive screening, personalized biomarkers, lifestyle modifications, and medications and supplements in a more proactive way. So preventative maintenance as opposed to repair shop mentality, with the goal of hopefully pushing out this health curve and shrinking sick span. I love the idea. I think that's insufficient to achieve the goal that we would really want to achieve. Certainly you can have an impact, but I don't think it's really going to push the health curve out as far as we would like to, or as far as is feasible in and of itself. And so I think what we really need to do is apply a sort of solid geroscience approach. So thinking more about the biology of aging and utilizing these new artificial intelligence tools that are coming online. And I'm not going to talk any more about that. My colleague, Dr. George Haddad, will be speaking, I think, next week or the week after. And I think he'll tell you more about clinically how he's actually starting to employ these tools. But that's the vision, that's the goal moving forward. And that's really what I think of as medicine 4.0, is integrating these geroscience and AI tools that are becoming available. So again, take a step back, looking at individual diseases in isolation. What is the greatest risk factor? It's not going to surprise anybody here that age is the greatest risk factor. The take home is, if we can understand that biology well enough to target the biology of aging, we can actually have an impact on many functional declines and diseases simultaneously. And that's exactly what we see in laboratory animals. And I would suggest that this is necessary, but not sufficient for medicine 4.0. I don't think we can push that health curve out as far as we want to without doing something about the biology of aging. Just to give you a little bit of an idea of how large the impact of age is, these are some of the common risk factors that are typically talked about for 4 of the major killers: cancer, heart disease, COVID-19, or you could probably lump influenza in there as well, and Alzheimer's disease. You can all see they're in the order of 2 to 3-fold. If you compare that to the effect of aging, 40 years, this is the same data, just now with aging added. You can see it's not even close. We're talking order of magnitude or 2 orders of magnitude difference from the effect of biological aging for 4 decades compared to all of the major risk factors that are typically talked about, probably combined. So age really is, I think, the biggest lever, if we can do it, that we can use to modulate health going forward. This is also true at the level of life expectancy. So this is based on demographic analyses, originally by J.L. Shansky, looking at the impact of curing cancer, curing heart disease, curing both on life expectancy for a typical 50-year-old woman. It's about 3 years for each individual, and it's about 7 years if you could cure both, complete cure. If you compare that to what is now routine in laboratory animals from modulating biological aging, it's a much greater impact on life expectancy, with the anticipated added value that most of those years will also be improvements in health span, because we have modulated many, hopefully all of the functional declines that go along with aging simultaneously. So the potential impact here is great. Again, we haven't done it yet, obviously, but I think the opportunity is there. Okay, so I already defined geroscience as connecting aging with disease. The hallmarks in principle give us targets we can go after. I do want to just say, I still think it's really early in the game for geroscience. I sort of compare where we're at with our understanding of biological aging with what the map of the surface of the Earth looked like in 500 BC. And all of that is just meant to say that we have a lot to learn. That doesn't mean this map wasn't useful in 500 BC, and it doesn't mean that our understanding of aging isn't useful today. You could use this map to explore, to get rich, to make political connections. I think we can use our understanding of biological aging today to have an impact on health span, and a significant impact on health span. But I just want to make the point that we have a lot more to learn than we already know about the biology of aging. It's immensely complicated biology. And so one of the things I've been thinking a lot about is, how do we get to medicine 5.0? I know we haven't got to medicine 4.0 yet, but how do we get to medicine 5.0, which would be to take this health and survival curve and push it out another 20, 30, 40 years. I think we don't understand enough about biological aging today to do this. We need new unbiased discovery science, we need new animal models, and we need to integrate the new AI tools. And one of the projects I'm involved in is Aura Biomedical. It's a large, high throughput longevity drug discovery company based on using some of these new technologies. And then on the new animal front is a project called the Dog Aging Project that I co-founded out of the University of Washington, which is the largest longitudinal study of aging in the world in companion dogs, with 50,000 dogs and owners participating in the United States. I think these are hopefully both projects that will contribute to helping us get towards medicine 5.0. All right, so what do we know today? We know aging biology is real. We know it's modifiable. I'll give you a specific example in a minute. We know that modifying aging biology is more effective than targeting individual diseases in isolation. We know something about the aging biology. I talked about the hallmarks of aging, useful but incomplete. We know something about how to measure it, these epigenetic clocks and other omics clocks that people are developing. And we know some of the key nodes in that network that underlie the hallmarks of aging. And one of those nodes is a protein called mTOR, which stands for mechanistic target of rapamycin. And we have a drug that targets mTOR. So I'm just going to spend the last 5 minutes or so talking about rapamycin, because I think right now that's our best candidate for a drug that has a robust effect in laboratory animals. And we're starting to see evidence that in the real world, it may have similar effects. Very early. Some of you may have seen this New York Times article that came out about a week ago about rapamycin specifically. I'm not sure exactly how I feel about this. I mean, it's good that that the field is getting attention, but along with attention, comes a lot of negativity sometimes as well. So it's a mixed bag. But in any case, this article was published in the New York Times. There are, I'm guessing, tens of thousands of people now taking rapamycin off-label based on the idea that it may improve health span. Obviously, we don't know yet in humans. Why do people believe that? So rapamycin is currently our best-in-class longevity drug from studies in the laboratory. I want to be clear, it's not a miracle drug. We're not talking about immortality. We're not talking about tripling lifespan. In mice, it can increase lifespan up to about 30%, but it's the most effective drug that we've got, and it's by far the most reproducible. It seems to work, broadly speaking, across different genetic backgrounds. And as far as I know, everybody who's ever tried to get increased lifespan with rapamycin has succeeded in mice. It works not only in mice, but in every animal where it's been tested, including now there's data in marmosets, which are a non-human primate, that rapamycin can increase lifespan. Importantly, you can start the treatment in middle age and still get most or all of the effects. That was originally shown by the NIH Interventions Testing Program. That's really important for a translational intervention. We don't want something teenagers have to take. We want something that can be initiated in middle age. And not only does it increase lifespan, but it appears to broadly delay, and in a few cases, even reverse functional declines that go along with aging in many different organs and tissues, a subset of which are shown it right here. I think the thing that's really exciting to me is the fact you can actually see functional rejuvenation in several organs and tissues. This is best characterized in the heart, in the immune system, in the oral cavity, and in the ovaries in mice. You can take an old mouse where there's already been functional decline, treat for between 6 and 12 weeks with rapamycin, and see significant functional improvements in all of these tissues and organs. And that, I think, makes sense from a biological perspective. And I don't have time to get into the mechanisms, but I think part of it has to do with the chronic inflammatory state that rapamycin is very potent at blunting, which then allows restoration of stem cell function and things like that. But this, again, is very encouraging from a translational perspective that you might actually be able to improve function with a geroscience intervention like rapamycin. Okay, so in the interest of time, I'm going to skip over some of the data. I do want to say the data on rejuvenating immune function is quite impressive. In a mouse, an aged mouse, you can treat with rapamycin for 6 weeks and essentially fully restore the ability of the aged immune system to respond to a flu vaccine. This is work from Pan Zheng's lab at the University of Michigan, published in 2009, and the reference is here in the slide for anybody who's interested in diving into that. And then work from my lab showed that you could reverse periodontal disease in aged mice using rapamycin. This is work of Jonathan Ahn, who's now a professor at the University of Washington in oral health sciences. Again, 8 weeks of treatment was enough to regrow bone around the teeth, suppress gingival inflammation, and at least partially reverse pathogenic changes in the oral microbiome of the aged animals. So those are pretty interesting. And then we did this experiment that asked a simple question, which is, if we only treat aged mice for 12 weeks with rapamycin, and then we stop the treatment, we put the mice back on the shelf, what happens to survival? And we saw that we could get about a 60% increase in remaining life expectancy from a 12-week treatment with rapamycin in aged mice. Alessandro Bito did this when he was a postdoc in the lab. Again, no idea if this is going to translate to dogs or people. If it did, linearly, that would be about 2 to 3 years for a typical 7-year-old mid-sized dog, or about 2 decades for that 50-year-old woman I alluded to earlier. So potentially pretty significant increases in lifespan and health span. So what do we know about rapamycin in the real world? So there have been a series of clinical trials from Joan Manick looking at everolimus, which is a derivative of rapamycin, or Rapalog, suggestive that transient treatment with everolimus for 6 weeks can boost immune function and flu vaccine response in healthy elderly people. It may protect against COVID-19 severity. This is data from people who were using rapamycin off-label. We published that in Geroscience last year. Good evidence now that it reverses hypertrophic cardiomyopathy in cats and may improve age-related heart function in normally aging dogs. That was a study that came out of the Dog Aging Project. There are a series of clinical trials happening right now. So at the Dog Aging Project, we have a randomized double-blind placebo-controlled veterinary clinical trial of rapamycin called Triad, test of rapamycin in aging dogs. 580 dogs will be randomized into this clinical trial. It is powered to detect a 9% change in lifespan. So lifespan is the primary endpoint. Of course, we're looking at a bunch of health span metrics as well as secondary endpoints. But that study hopefully will answer the question, does rapamycin increase lifespan and slow aging in companion dogs? There were recently results released from the Pearl trial suggesting that very low dose rapamycin may improve body composition, specifically in women. So preservation or gain in lean mass and reduction in visceral adipose. There's a clinical trial from Zev Williams and Yushin Su out of Columbia looking at effects of rapamycin on premature ovarian failure in women based on the studies in mice. John Ahn is leading a periodontal disease clinical trial in people, again, based on the studies in mice. And Brad Stanfield just recently started a clinical trial looking at preservation or gain in muscle function in elderly when combined with exercise. So I think, again, all of these are small clinical trials, but hopefully we'll start to get some good clinical trial data on whether rapamycin can have an impact on biological age-related phenotypes in people. And you have almost too many things that you could look at with rapamycin based on the mouse data. So I just want to finish up. This is the last slide by suggesting rapamycin, I mentioned, is the gold standard, but it's not the only thing. So all of the drugs here have been shown to increase lifespan by at least 10% through the National Institute on Aging Interventions Testing Program. This is a group out of the NIA that does triplicate replication lifespan studies in mice. So there have been several things that have come out of that. The 3 that are highlighted in red, I think, are interesting because those also came out of a recent association study from the UK Biobank looking at prescription medications in the UK that are associated with lower all-cause mortality compared to health-matched cohorts. So if you're interested, that is a preprint on medRxiv. I just think it's very intriguing that these things that have been shown to increase lifespan in mice from the NIA also seem to be associated with lower all-cause mortality in humans. Doesn't prove anything, but it's an interesting observation. So there are several candidates out there that are worth studying. There are more coming down the pipeline. And so I think it's it's very likely, if not as close to as certain as I can possibly get as a scientist, to say some of these are going to work in dogs, some of them are going to work in people. We really just need the tools and technologies and resources to go out and figure out which ones and at what doses and what does the safety profile look like. Where's the risk reward? Okay, with that, I'll just stop. Mention we have a podcast. We do a deep dive on a bunch of these topics. If anybody's interested, I'd encourage you to check it out. And thank you for the time and the opportunity to talk to you today. I'm happy to stick around for questions if we've got time.
Yes, thank you, Dr. Kaeberlein. Very, very cool to see. And again, a couple of serious take-home messages. First of all, gerosciences, I hadn't heard that before today. I clearly need to put that into my intake perspectives. I think it's a fascinating theme. And six-span is a enormously meaningful term, actually. You had highlighted that, it kind of almost got lost, but I want to just bring or tune in the audience of that concept of six-span in your various life expectancy curves. This is, as we look at healthcare economics, a huge insight with an aging and sicker population. So six-span, I hope the audience will dive into that and adopt that into their nomenclature and conceptual assessments. For me, the single biggest thing that strikes me with your basic research is the use of anti-inflammatories and antibiotics. Many of our patients present with unbridled inflammatory diseases that manifest in the spine with these large bridging osteophytes or unbridled collagen collapse. And there's clearly something overwhelming going on in the body, even in people who've been pretty conscientious in their lifestyle. So my question is the following. Now we have a greater awareness of our gut microbiome. There's a emerging thought about the brain biome. You have obviously focused in your work on the oral biome. So having a healthy collaboration with living microbiologic colonies in our body not being a sterile environment, is a big deal. The influence of antibiotics kind of modulating that or impairing that is still kind of overwhelming to me. How can we kind of conceptualize having a healthy microbiome by giving an antibiotic? And we don't even know about the brain biome except for very basics. So how can an antibiotic with a selective interference with a healthy coexistent microbiological colony help us?
Yeah, I mean, so there's a lot to unpack there. I think the first thing I'll answer the specific question about the antibiotics. So the literature is actually pretty interesting here. There are a variety of studies in laboratory animals where antibiotics are associated with positive outcomes in terms of lifespan and at least some health span metrics. I think the interpretation would be there's a dysregulation of the microbiome with age that may be downstream from immune dysregulation. And if you treat with an antibiotic, you can kind of wipe out the bad microbiome. And if you repopulate it with a good microbiome, that has some benefits. I think the challenge, of course, in people is what does that mean to repopulate with a good microbiome? And if people are eating a low quality diet, it's very unlikely they're going to repopulate with a good microbiome. So in that case, antibiotics, I think, as we're learning, can have negative consequences in a variety of ways. Unfortunately, it is my perception, and I'm not a deep expert in the microbiome, it is my perception that we're still pretty early in terms of being able to understand what is a good microbiome and what is a bad microbiome. And so I think we need to get a little bit further down that road before we can really start to talk in a therapeutic way, I think in a really sophisticated therapeutic way about that. My sort of crude, simple-minded approach would be if you need to take antibiotics, then eat a healthy diet when you come off the antibiotics and make sure you get lots of fiber. Do your best to repopulate a healthy microbiome. But I want to touch on the inflammation part because the microbiome is one of about 4 hallmarks of aging that can drive inflammation, which is also a hallmark of aging. So DNA damage can drive inflammation. Mitochondrial dysfunction can drive inflammation. Senescent cells can drive inflammation. So I think what we see is inflammation is sort of a second tier hallmark of aging, and there are multiple types of damage that can cause age-related inflammation. And the specific, I think, types and consequences of inflammation with aging, especially how they may differ across different cell types and different tissues, is going to be really important to tease out, because I think that's probably the easiest therapeutic place to look first. And I think rapamycin fits right into that. I didn't have time to really go into it. Rapamycin was first FDA approved as an organ transplant drug because it acts as an anti-inflammatory. Many of the drugs that we see increase lifespan have anti-inflammatory properties, but not every anti-inflammatory modulates the biology of aging. So we really need to understand what types of inflammation are happening with age, where they're happening. I sometimes suggest that aging is, to some extent, an autoimmune disease. We see a lot of increases in autoimmunity with age, sterile inflammation, reaction to things that the immune system normally wouldn't react to. But then, as you alluded to, we also have changes in the microbiome that are driving an inflammatory response that is appropriate. It's still contributing to this overall hyperinflammatory state.
Fantastic answer. And I have one more question. We got to conclude here, but you have kind of propagated metformin as being a beneficial thing. I personally, as a clinician, don't like it, and I am not an endocrinologist.
I have not propagated that. But let me give you my comments on it, actually. I think it's interesting. So metformin has been sort of talked about in the field as a drug that targets the biology of aging. It was very quick on my slide. It was kind of down at the bottom of something else that people talk about. Metformin, I think, is a very good drug for people who have metabolic disease. It works well for diabetes. It has some problems as well, and I don't think metformin is a potent drug in terms of modifying the biology of aging. I think diabetes and metabolic disease accelerates aging. If you have diabetes and you take metformin, you will see a signature that looks like improved aging because you have improved the metabolic dysfunction. That's my personal take right now.
Great. No, thank you. Thanks for cutting me off right away because, again, I think it is a actually precarious drug and it's a false hope drug. So I think we're probably actually, I just want to encourage the audience to who do podcasts, listen, pull up Matt Kaeberlein. You see his spelling on your podcast search tool. It's an amazing lexicon and diversity of thought-provoking topics, and it's really cool to listen to with a who's who in the anti-aging community. And thanks for introducing us to this fascinating field of gerosciences and putting up with our spine perspective of the world. And I hope that we can fit into your general big picture assessment of humankind and wellness aging as opposed to sick span. So thank you, Dr. Cable.
Thank you. It's been a pleasure.
Really enjoyed this. Okay, take care.